Dear colleague, dear faculty, thank you for your invitation. In this short presentation, I will talk about a possible correlation between regional pressure, hemolysis, and D-dimer during ECMO. Hemolysis can be a difficult problem to control in patients during a CLS, and is associated with increased morbidity and mortality. Hemolysis in the patient on ECMO is most likely to be due a complication of mechanical support, but could be suggest underlying condition such as intravascular hemolysis, which increase plasma-free hemoglobin. In fact, the rupture of a red blood cell releases free hemoglobin into the plasma. Free hemoglobin is cytotoxic, resulting in tissue hypoxia and cell death. Free hemoglobin scavengers release nitric oxide, leading to inappropriate vasoconstriction and endothelial dysfunction, and as a consequence, severe complications such as renal dysfunction or multi-organ failure may emerge. This promotes thrombosis by von Willebrand factor-mediated platelet adhesions. In recent years, several near-technical optimized ECMO systems have been developed, but technical induced hemolysis during ECMO therapy remain of concern, which are reported incidence between 5 and 18%. However, data from clinical practice in adults are scarce, and no systematic analysis has been undertaken in a large cohort. Major contributor of technical induced hemolysis may consist of sublethal damage of erythrocyte by high-velocity blood flow or shear stress, excessive negative pressure by chattering or cavitation, and pressure change within the oxygenator. The degree of hemolysis is routinely monitored by plasma-free hemoglobin, lactate dehydrogenases level, and aptoglobin testing allow detection of subclinical event, and can rise significantly during ECMO therapy. In according to ELSO, a free hemoglobin greater than 50 mg/dl should be investigated. Another important value during ECMO is the dimer plasma measurement. It's represented by plasmin activation and fibrinolysis. It might be an alternative marker for early diagnosis of thrombus formation and expansion of heparin-coated membrane oxygenation. In this interesting report, all data originating from the ECMO run were collected to analyze the effect pertaining to the development of hemolysis, which included different pump and different cannula type, the duration of ECMO, and the diagnosis leading to lung failure during ECMO therapy, the blood flow, and the amount of red blood cell. Free hemoglobin value were independent from the pump type and the cannula type. Neither which induced the increase of free hemoglobin on ECMO. And it is well known that a high negative pressure of, for example, by the kinking of line of obstruction of the flow can cause cavitation and hemolysis. Therefore, in this report, it was impossible to describe the direct effect to excessive negative pressure on hemolysis, but the efficiency of negative pressure on the increased free hemoglobin seems to show no different about the type of cannula used. The aim of our study established the correlation between ECMO functioning and hemolysis, and established the correlation between D-dimer values and hemolysis. It is a retrospective study on adult critical care. Patients require ECMO in 15 patients between April 2013 and to February 2017. The type of ECMO were for 10 patients ECMO VV, for 3 patients ECMO VA, and for 2 patients ECMO VVA. The type of pump were Rotoflow and CardioHelp, and the average of ECMO duration was 13 days. The materials and the method, we measured the revolution per minute, maximum inlet pressure, blood flow, maximum D-dimers, maximum plasma-free hemoglobin, and minimum aptoglobin. Using statistical analysis to evaluate the relationship between maximum value negative pressure and the degree of hemolysis seemed to suggest an inverse correlation, that is to say, the increase in negative pressure will increase the degree of free hemoglobin. And in this slide, we can see the relationship to maximum D-dimers and the value of maximum free hemoglobin during ECMO run. There seems to be a correlation between high free hemoglobin levels and D-dimers value. In fact, D-dimer is a residue of destruction of fibrin macroaggregate, which are formed not only during coagulation, but also a severe inflammatory event that causes in microcirculation microcoagulation. With the exposure of the cellular debris, we hypothesized free hemoglobin as the root cause of microthrombosis, which can result in the increase of D-dimers. It's unclear whether this phenomenon occurs in the patient or in the oxygenator. In this slide, we can see the correlation between the value of free hemoglobin and the aptoglobin. And there is an inverse correlation between maximum free hemoglobin and minimum aptoglobin. However, this is not a reliable indicator for hemolysis because aptoglobin remains bound to free hemoglobin for many times. And for this reason, it cannot be used as daily monitoring. And the most significant indicator has been identifying the dimers value and the free hemoglobin value regarding information about inflammatory response or thrombosis and hemolysis. However, the precise mechanism has not been identified yet, and it's necessary to have a study with a larger sample size. There were no significant correlation between maximum D-dimers and minimum aptoglobin, RPM, blood flow, glass flow, and maximum free hemoglobin. And our study suggested that a high negative value of drainage pressure could result in high level of free hemoglobin. It could be estimated that free hemoglobin trigger the increase of the D-dimer possible through immunomediator or inflammatory pathway, and the inverse correlation between free hemoglobin and aptoglobin confirm the reliable value of the collected data, and it's very important to keep under continuous monitoring the drainage pressure. This is my fantastic teams of perfusionists. Thank you for your attention.